So good night or good evening and welcome to our session. We are really glad that everybody's here. I'm not sure, and I'm going to ask, is everybody hearing the doorbell or is that only me? Okay, good. I'm hoping nobody else is hearing. It's my pleasure to introduce Dr. Susan Wiley. Dr. Wiley's a developmental pediatrician here at Cincinnati Children's Hospital Medical Center in the Division of Developmental and Behavioral Pediatrics, and she's a professor of pediatrics at our University of Cincinnati. She's trained under Dr. Rubinstein and has dedicated her career to providing clinical care to children, adolescents, and young adults with Rubinstein-Taybi syndrome. In addition to this work, she also serves as director of our Thomas Center for Down Syndrome, and she's also the co-director of our Charge Syndrome Center here at Cincinnati Children's. Dr. Wiley is deeply committed to supporting both families and providers. She's worked alongside us at the University of Cincinnati Center for Excellence in Developmental Disabilities here at Cincinnati Children's to develop educational resources and has helped foster connections through the RTS OKI network. She was part of the folks that really created that family support group back in the day. We're honored to have Dr. Wiley with us today to share her thoughts, insights, and expertise. So if you will please join me in welcoming Dr. Wiley. Thank you for coming.
Thanks, Celia. That's a very nice introduction, and I'm having fun. I'm going to have to take my eyes off the chat, just seeing where everybody's from. It's a lot of fun, and I'm so glad you're all here. We can move forward. So on the slides, please. So I thought I'd start with this picture, and there's a little bit of me that goes, a transition topic could be a week-long conference, right? So there's so many aspects of transition, healthcare, participation, community, finance, supported decision or decision-making, legal kinds of things, so again, I would defer greatly to Dr. Riddle and Celia, who do a lot of talks on transition. So I'm going to kind of lean on them a little bit as we go. So I just thought I'd, talk about the complexity of that and know that I can't probably cover everything. So we'll go to the next slide, please. But what I hoped we would do today is at least describe a little bit about what we think we know. And I say that what we think we know about teens and adults with RTS from the literature, and also think about how those gaps in care and approaches to how do we address those gaps and advocate for improved care and supports. And I also recognize that you all are the most experts at this. And so what I'm also hoping is that we have a little bit of opportunities at different junctures in the talk to have a little bit of either conversation or chat about what you all have learned and figured out and how we can support each other. So next slide, please. So one of the things that I just wanted to kind of step back, because I think even when, I look
Hey,
at
hon.
Oh, hello? Oh, okay. So when I think about even looking at papers, some of the things I think about is oops, go back again. Sorry. I don't think there was a timer. Yeah, there you go. Thank you. Partly what year, how old were the people in the cohort, meaning, when were they born, what was happening at that time? That gives us context around the outcomes, because some of the literature is older, and we also know that educational systems have advanced, medical systems have changed. And so when we look at the older folks that are in the literature, how does that apply to maybe a child who's born today? It's hard to make that direct comparison. I think the other thing I look at when I look at studies is, how many older folks are there in these papers? And some of them do have some nice inclusion of older individuals, but also particularly EP300 is really one of those subgroups of kids with RTS that really hasn't had as much data yet. And I think that's hopefully will still keep evolving. And then also just when we reach out to people for questionnaires or information, it's helpful to realize, not everybody answers back. So, those who might be more inclined to reach out and answer some of these questionnaires might either be feeling really good about things or really struggling. And so, there could be some bias in that. And then I also look at country of origin from a very respectful way, I guess I would say, because I think when we think about those educational systems or intervention systems or healthcare and how is it administered, there may be differences across countries. In fact, when we put together the first RTS guidelines and had some of the folks from Europe look at it, they were like, well, we wouldn't do that because we wait and see if there's a problem versus proactively getting say an echo on everyone. So just even that kind of philosophy of care can be different. Next slide, please. Okay, so I'm going to try to hit all of these topics. We'll see how it goes. Puberty and sexuality, health conditions, dental care, adult health care, skills and independence, and behavior mental health. So let's rock and roll. Puberty is always one that is scary, right? It does feel like within the population of individuals with RTS, there's been a lot more described in girls than boys. We tend to see the periods start at about 13 to 14 years of age. There were two different studies. One was, and Dr. Stevens has done the majority of this work, one from 1990 and one from 2010, with a little bit of variation in that later study. But I would, looking at that data, the later study had a person who didn't have a period until 28, and that seems like an outlier problem and that should have kind of warranted some workup. I think the other thing that's important is to know that fertility is possible. And because RTS has an autosomal dominant pattern, meaning, you only need one gene, and if you have that, you are affected, that a child of an individual with RTS has a 50% chance of having RTS as well. You can go to the next one, please. So I think when I guess too, I was like, it helps to kind of know, especially if you're facing puberty, what are we going to see and when are things going to happen, right? So typically for girls, the first onset or the true puberty, so we always think about, well, pubic hair, underarm hair, or smells, those are going to happen. But for girls, the first true sign of puberty is really moving through is breast budding. So and typically once their breast budding occurs, you have about 1 to 2 years after that to have to start where periods start. And also those first periods can be very light, can be very irregular. So I guess why I say that, and I talk to families a lot about this, is it kind of gives you that relief of, okay, I kind of know a little bit more about when things might occur, and then I can be a little bit more prepared. For boys, the first sign of puberty is testicle growth, which is also not necessarily something that's easy to overtly recognize, but that is kind of the first sign of true puberty has started. So I've also tried to embed some of the newer international guidelines into these slides. So one of the guidelines that's kind of linked to puberty is that they really did, encourage sex education, including contraception and family counseling that's adapted to the developmental level of an adolescent or adult with RTS. And that, it is important to understand our bodies and understand what can happen. So next slide, please. And I think too, like, I know puberty is a scary thing. And usually I get do we really have to start this? Because sometimes kids can be delayed with their puberty. And yet, puberty is also really important for bone health for both boys and girls, which is why we kind of push folks, even if your loved one is kind of having a late start, and that's kind of helpful and reassuring. Typically, what we would say is delayed puberty is if a girl does not start periods by the age of 15, or I said, you usually have 1 to 2 years from breast budding to period. So if you started having breast buds rather early and it's been 3 years since that happened, that's still something has kind of gotten in the way of that progression. And boys, if they have not shown any signs of puberty by 14 to 15. And typically what we would do at that point, and I think this might, if people really want to delve more into this, we have some great folks who do a lot of this kind of care and could talk more about specifics. But typically we'll look at hormones to kind of see, well, are you entering puberty? Do we need to treat you? And again, that's probably going to be more linked to the estrogen needs for bone health in girls and testosterone injections for boys. And I get a lot of questions about that, is like, why would we give testosterone when it's going to, everybody thinks, oh, that's going to make you aggressive. It doesn't always. And so I think, again, we're really thinking about health and growth. The RTS guideline it's also just kind of talks too about the fact that girls can have very heavy periods or very painful periods. And in general, that is well managed by by hormonal contraception or birth control. So, and that we do this for all folks, right? Well, all girls who have heavy periods that are really interfering with things, we may actually talk about that as an option to kind of manage that. Next slide, Pete, please. And I think too, what I guess my sense of particularly menstrual management is that there's a lot of approaches and not one size. There's not a one size fits all. And I will often really offer folks to talk to a pediatric gynecologist or adolescent medicine specialist before the periods happen, because then you can actually think about the different options. You can study, you can kind of do a little more research on that, and you have time to consider an approach. Typically, we would not start any sort of menstrual management until a girl has a period. But again, that first one's usually pretty mild. And I think the other thing that most people worry about is you don't have to have a pelvic exam to get started on something. That isn't necessarily a requirement. And I think that's another kind of, fearful place, which makes a lot of sense, is, what's going to happen at the exam? How do I prepare my loved one for that, and kind of, have that information. All right, next slide. And I think too, well, I said that, our bodies do change, and it's very natural, and it's, their kids are going to have a natural response. And so understanding that early, feeling, I think about, like, how do you talk about this? I probably learned more in medical school than from my parents, and how, my parents talked about it. And again, that is partly how we learn, right? So how was that talked to? How did we learn about it? But then how do we convey that in a comfortable way, in a way that kids can understand, and then also doesn't become, I guess, fodder for conversations with everybody on the block, right? So what are we coaching our loved ones to kind of understand, these are things that we talk about here. And but I think the other places where families kind of worry a little bit are things about, being overly friendly or hugging. And that's cute when kids are little, but not as cute when kids are older. So, we don't want to limit the love and joy that our loved ones have, but again, trying to find that balance. Boys will have morning erections, boys and girls will masturbate. Those are things that too, we are natural. And then how do we teach the locations and safety principles around that? So, that doesn't happen on the bus. It doesn't happen at school. That's a private activity. And then, of course, people worry too about victimization. That's a common concern for many families. And to some degree too, we encourage, anyone with an intellectual disability to also get the usual preventive care. So the HPV vaccine is one that has been given to both boys and girls to try to reduce the risk of cervical cancer. So again, as much as we might think my loved one's not going to have sex, the worry about victimization is another reason to kind of consider that. And then, many people do want to date, and how do we support that as kids get older and find their social network? I do often, we use this toolkit a fair amount. Vanderbilt did a nice Healthy Bodies toolkit. So it has some of the kind of general information about how our bodies change. Also has some nice information about that social circles, who I might give a high five to and who I can hug or, say hello to. They also have some nice resources to make visual schedules, so that if we're thinking about you know, I got it. My new morning routine has to include deodorant and this and that and the other. That can all be kind of included in, or shaving and so forth. So that's a nice toolkit, and it's freely downloadable, and I believe it is in Spanish as well, which is also nice. There's one for boys and there's one for girls. And then the supplement has a lot of the tools to help with the visual schedules. Okay, we can go to the next one. I'm going to keep my eyes on the time here. So I'm curious from the group, like what fears you may have had, what experiences you've had, and what strategies you found helpful. So I don't know if we want to try that in the chat, or if people want to feel comfortable enough to unmute and speak up, because again, my thinking is I learn so much from families, and that's usually where I feed forward information.
I know there's got to be folks in here that have great information. Oh, it looks like Leanne's turning her camera on, maybe. But anybody who's willing to chime in, it's always helpful to keep these things going. Great, Andrea. Thank you.
I have a question. Well, my daughter Tula is now turning 17 on the 14th of this month. And yeah, and you diagnosed her almost exactly 10 years ago when we came out to Cincinnati. And she has gone through puberty. We happened to delay her onset of her menstruation just because in speaking with our endocrinologist, there was the thought that maybe if we give her more opportunity to grow, to allow her bones and her, muscle tissue to grow before puberty starts, because that really kind of nails the coffin, nails
Yeah.
the nail in the
Yeah.
coffin for, potential growth. And I guess once you get your period, you do 18 months more, I think, of growth, and then you're pretty much stalled out, very minimal.
Yeah, that's a great point. That is an absolutely great point. And that's also why if kids start puberty early, we actually want to stop that and prolong it. So I think it is a balance with, individual choices and thinking about height, because as somebody who's a little bit short and I still use, stepping stools, we do want kids to be able to reach things and participate and, be as tall as possible. So I appreciate that additional thought process.
I do have a concern though. So you did mention something about using hormone therapy for painful, periods.
Uh-huh.
And Tula happens to, probably because she inherited it from me, where I have endometriosis, has really painful periods where she even needs to miss school because
Yeah.
of it. So I don't know if that's something that we should, search further.
Well, yeah, no, and I'm seeing in the chat too that there's a 20-year-old Sarah's daughter has had some pretty heavy periods, and that progesterone has been helpful, because I think too you are right that it could have a familial perspective, and it's also been reported more commonly in girls with RTS to have heavy painful periods. So again, it kind of really I think each person has to have those conversations. Is this interfering with life? What do we want to do about it? What are we comfortable with as a family regarding hormones or other options?
Okay.
So there's numerous things in the chat, Susan, a couple of them talking about late periods or no period yet, and painful periods. And I'm looking, one of the folks, as far as their fears, is she's most afraid of her daughter passing it down with her 50% chance because she has RTS2, and she agreed with the 12-year-old breastfeeding and the 14-year-old beginning a period. She's 4 and they're waiting on whether or not she will be social enough to date, but she is worried about.
I mean, I think it's, we always fear the futures of our kids, I think. I mean, I think that's fair. And I think too, I guess it's really important to have both that concept of dating could happen and marriage could happen, not to say everyone is, heading in that direction, but, that is what we we do as a society. So I think too, I saw somebody using period panties, which I think is also nice. And because again, sometimes the sensory stuff of a pad is not very, like comfortable for folks. And, so I'm seeing some folks use that. That's also a nice approach. And again, I think, I have a lot of families who go like, we want to give it a try, but we want to talk about what our options are, because if it goes okay, we're going to keep moving forward. If it doesn't, then, what do we do to help? And so again, so I'm seeing some things about moodiness around periods. Sometimes kids can be more aggressive and mean. The I think too, sometimes we either do menstrual management or sometimes we, if you have a lot of premenstrual symptoms, we may actually think about some medication to help that as well. I see a question about, so girls the estrogen basically closes their growth plates. And so once they start having periods, they don't grow as much. So if you think about like sixth graders, the girls sometimes are taller than the boys, and then the boys take off, and the boys actually start growing more after they've started puberty. So their time of growing is longer. So yeah, you can get some more height out of boys for a longer period of time. And I think the question, like there's one that's talked about some, scoliosis, and with growth spurts, you can see that a little more prominent. So all right, this was a very
Susan, real quick, Jennifer had her
Oh.
hand up real quick that she didn't put hers in the
Okay,
chat.
sorry. Thank you.
And there's
I'm not,
one other question that we haven't touched on, but go ahead, Jennifer.
Thank you. So I just had a quick question. We went through puberty all right, in terms of certain levels of maturation, and then we did growth hormone therapy to achieve height issues, but no one ever suggested testosterone therapy. My only concern was, in my son's case, his reproductive organs are underdeveloped, so testes and I just wasn't sure if that was something that's unusual. He doesn't seem to have a problem with it, but
right. So testosterone injections are usually used when a person's testosterone is low or they haven't started puberty. So, or like, so I think if everything was fine, you're right that boys may not, particularly because their testicles are often, need to be pulled down and that sort of thing. But in general, it's really only when we're seeing issues with low testosterone would we actually encourage that. So we don't want to give super testosterone levels. We want to just give what kids would need for their health. All right, we should probably move on. We could probably talk
One
about this
other
one.
question, Susan. I'm sorry.
Okay.
There's a question about any recommendations for a daughter who is still like in diapers, but is moving into teenage years.
Yeah, I mean, I think those are decisions that people have to make independently, right? So sometimes people say, well, adding a pad to a diaper is not that big of a deal. However, that also might be, well, they're, nothing against any dads, but they're going to dad's house and that's uncomfortable for dad to manage that. Which, I'm not saying all dads are uncomfortable with that. So I do sometimes see families go, we're hardly managing our bowels and bladders very well. I can't imagine adding one more thing. And then there are things that we can do to suppress periods altogether, so that there are approaches to make your periods light and non-existent. So again, I think maybe we ought to have a gynecologist come on and talk more about that. So probably be maybe we try to do a boy and a girl thing.
Yeah.
Yeah. All right. Well, let's keep it moving because I know I only have an hour left and I'm thinking, I spent too long on puberty, but that's a huge important one. So this one may not be, I think there's still a lot of stuff that we see into adulthood. So again, the papers that I kind of hit upon most one was a 2022 paper and another was Stevens, who's done a lot. Again, 2010. So that's an older cohort, but on the 2022 paper, 85% of adults had at least one medical issue and most had more than one. And you guys probably already kind of recognize that because, you know, whether it's constipation, whether it's skin issues, sleep problems, and those are high in adults as well. So things don't necessarily go away as soon as we grow up. And so we're seeing a good number, excuse me, a good number of those conditions. What I was a little concerned about from Stephen's cohort, and again, maybe there's some differences now, but, or no, that was actually the 2022 paper. They actually asked families, do you have a regular doctor, like, or provider, so a community nurse practitioner, PA, whatever. But only 40% of folks went yearly to their well care. So again, in adults, I mean, I know a lot of adults don't go yearly either, but there are things that your doctor should be monitoring for. And then only 30% only went when there were concerns. So that also speaks to a gap in adult health care. We'll go to the next one, please. So I went ahead and tried to put a little bit of the data in here. Just, I mean, you know, it's not, you can download it or look at it another time. But constipation is a really common issue into adulthood. Reflux is still an issue, so where things kind of come back up. What also, though, I think was interesting from Stevens is they also talked a little bit about some difficulties with chewing and choking, food stuffing. So those were more behaviors they were looking at, and I don't think that was necessarily asked in the other study. Two of the folks in Stevens' study had eosinophilic esophagitis. That is also something that I don't think we were looking for as much back in that era, and now we're looking more. So you might actually have that diagnosed as a kid, and then we're still managing that over time. And that's basically irritation in the esophagus that's more of an allergic kind. It's got the types of cells that are there kind of indicate that there's some irritation based on perhaps what we're eating. Okay, and then there's a whole treatment for that. Thank you for moving on. Yeah, I'm seeing some EOEs in the chats. Skin issues, keloids are common. I think that's kind of where you can get a very deep, a big scar, even if you just kind of hit your skin, you know, hit something, you might get a big scar. But also the toenail issues, and I think I think I don't know if Dr. Simpson's talked to this group, but she talked a lot about ingrown toenails and how much that can really be a problem in terms of, I mean, it can be painful, and how do you kind of keep that at bay? So I think some folks would probably benefit from a podiatrist. Those are the folks who tend to, in adult world, do more with toenails. And let's keep going there, and then I will look at the chat, I promise. Sleep apnea is also quite common into teens and adulthood, as well as, so I think too, the 2022 paper talked about increasing need for sleep. Well, if you have sleep apnea, often one of the signs of sleep apnea is daytime sleepiness. So you're sleeping at night, but you're not getting a great night's sleep. So you're often sleeping in the daytime. And then additionally, just as much, I guess, were some folks who also had trouble getting to sleep, staying asleep. So the sleep apnea is definitely something that we want to keep our eye on. And again, that was one of the international guidelines, is that we do need to be aware that this occurs, and it can cause health problems. So typically what you'll see over a long period of time, if it's untreated, it can actually put some pressure on the heart and have longer term issues. And I mean, I also would say, I know this is not a fun one to have, because like, is my kid gonna tolerate intervention, whether that's a CPAP mask or other things? Yeah. And then we do have some who just don't like to sleep. That's for sure. All right, and then let's see the next. So I think one of the linkages to sleep apnea is being overweight, and that's also relatively common in older folks with RTS. And that also can be associated with things like diabetes and hypertension. What was interesting, and I think I have this on the next slide, is that guidelines did not, they kind of indicated that we should monitor for high blood pressure and diabetes and things like that, just as we would with anybody, but, you know, any adult, but that they didn't really see it in a higher rate in individuals with RTS. But what I would also say is the majority of the cohorts that are being looked at, or the data that's there, are a little bit young. So high blood pressure tends to be more problematic as the older you get. diabetes can be associated with being heavy. So, but I think again, there's also the potential, because that paper that we talked about, I don't even go to the doctor every year, is would you even have recognized that? So I think if we're going to be proactive and try to keep healthy, that yearly visit and checking blood pressure and labs, sometimes the adult providers will look at like pre-diabetes and labs for that. And particularly when folks are heavier, that's important to do. All right, next slide, please. So the RTS international guidelines were, do what we usually do. But if the blood pressure is high, check on the kidneys as well. And again, that's something that when usually at diagnosis, we would ask for a kidney ultrasound, just because we know there can be differences in how the kidney was formed. But, and then again, they said it's a low frequency for diabetes and hypertension and cardiovascular issues. But I mean, I don't disagree with that entirely. I just think, I think we don't know yet if there's a higher risk. All right, let's see what the next one is. Okay, I want to try to quick look into, let's see, just making sure the constipation. I mean, I think constipation, well, maybe we talk, that's a hard one. I know we've had GI docs here in the past. And oh yeah, sorry, I'm like ADD here. The experience of not having a very good experience with podiatry because they didn't really get how to work with your child. That's not a helpful approach. Yeah, no, I thank you for people kind of sharing some of the stuff you guys have experienced. That's really helpful. So Stevens also kind of did a survey. Again, it was a bit of an older publication, but high rate of vision issues. Again, the keloids, again, some difficulty eating, spine curvature, joint problems, and we'll talk a little bit about that too. And then kidney stones in 5%. So that just, you can kind of walk. Oh, what is entailed in visual difficulties? That's a great question. I think it was more like I'm using glasses, but it can also be, some folks have glaucoma and other, they have folks with coloboma, if it's on the retina, can be at higher risk for like retinal detachments and things like that. I think it's a good question about osteoporosis too. Probably, there's probably not been enough looked at there on like the data. So I know that's also another area that we want to encourage bone health, because bone health is, again, we talked about puberty, but being weight bearing and, being mobile helps us with our bones. And then calcium and vitamin D intake, but also we have to look at medications that might interfere with your bone development too. So sometimes things like seizure medications can affect bone health. So let's hit the next one. I'm sure I've missed some chats. Wow, we've got some young folks with osteoporosis. My hope is you guys are also getting to like an endocrinologist to really kind of drill down on why that might be. And I think people have kind of hit on this, right? So why the orthopedic and joint issues are important is it's so linked to mobility. And we can see a higher rate of spinal curves. Well, at least the Stevens cohort did. Lots, a fairly high risk for the kneecap kind of slipping in and out. And then when you see those sorts of things, plus you have that low tone and maybe flat feet, you may end up with like a higher rate of arthritis. So again, we want to keep folks mobile. And if you've ever heard Dr. Melman talk, he's like hips, knees, feet. We got to keep everything aligned well and be proactive. Again, I don't want people to have surgery that doesn't need it, but the more we can keep folks active and independent, that is really important. And so the guidelines are monitoring that curve, and that's something that many pediatricians would do with what's called a scoliometer. So there's like a little thing that kids will bend over and you can measure a little bit, and if there does look to be some asymmetries, then x-rays, and seeing orthopedics in an ongoing way, because then they'll monitor and make sure, is there something we need to do more proactively. Again, Scoliosis is important for our lung health, particularly if it's rapidly changing. If one side is a little more smushed than the other, it can cause some issues on the lungs. And then, yeah, so the recurrent fractures in bone density. So it looks like our folks have had a fair amount of that. Yeah, oh, yay, I'm glad there was a good 2 thumbs up for Dr. Melman too. Looks like some scoliosis bracing and surgeries. So I think the fractures, so I'll just take I'll try to look back here a little bit. Sometimes if you have a fracture that like, oh yeah, I fell off the playground equipment and it kind of makes sense. One is okay, but like when we're doing that a lot, so there's 2 pieces of that, or like, am I just so impulsive that I'm making bad decisions, or do I have a weaker bone? So again, if you have a lesser of a trauma, I would be more concerned, that caused a fracture, I would be concerned. I think the other challenge though is sometimes kids don't have the same level of pain awareness. And so they might be walking on something that's broken. And that's another, you have to be really vocal as a parent to, let people, hey, I think we really need an x-ray, because we don't always, my child doesn't always complain about things. So, okay. And I think
Susan, just real quick, there was
yeah.
a question, I think, of a couple of parents with pretty young kids still wanting
Yeah.
to know about the constipation. That seems to be an ongoing issue throughout their lifespan, correct?
Yes. Yeah, it is. It is. And I see some folks too. So I think didn't we have a neurosurgery come once? There is a higher, so it's interesting to say, like when we did the whole international guidelines, the international folks were like, we have yet to find a tethered cord. And I'm like, we find them all the time. A tethered cord is basically at that base of the spine. You can have like a thicker area that's okay, but if it sticks and pulls, then your nerves don't basically work as well on the very bottom part of the spinal column, and that affects things like bowel and bladder. So if we've done a lot of constipation management and we're still struggling, or sometimes what you'll see is a hairy patch or a deep dimple, we might actually look at the spine to see, is that contributing? I definitely have had some folks where you kind of need somebody to look at that in a way that they understand what is a true tethering and also listen at the same time. So sometimes we have to do other testing to determine if the nerves are working well, whether that's motility studies or what's called urodynamics. It looks at how the bladder empties. But those are all things that may guide us into what is needed. What you may see too is you were continent and then you lose it, or your gait changes. So there are other things that, particularly because sometimes you can see problems as kids grow, and that may that stretch on the cord. So I think looks like there are some folks who've had that experience of having a detethering the spinal cord. I think the key is trying to do it before the nerve damage is permanent, right? So like sometimes you can do the surgery so you don't get more nerve injury, but it may not get you everything back that you were hopeful. And yeah, and I think too, like even the potty training, maybe we should do one on potty training at some point, because it's really multifactorial, right? There's an element of constipation management. There's an element of awareness. There's an element of willingness. And then how do we work together if there's a behavioral component and a medical component, that we need kind of that broader perspective. So, all right, what's my next slide? Hearing and vision. I think too, I'm a big one on, yes, please, for the potty training. Okay, we're going to have to find some really stellar people. Hearing and vision are important. And I think when you think about, so, aging population, what will cause a lot of isolation and loneliness is not being able to hear what people are talking about and not seeing what's happening. So again, it's really important to be proactive about vision and hearing. And it's also like, we also recognize, like, I think there's been some studies of folks in Special Olympics where we've not recognized the vision and hearing needs. So again, 80% of teens with RTS use glasses. and then there's fewer lower kind of conditions. And if about 40% had a hearing loss in Stephen's paper, but about 30%, 20% of 30% of that 40% were using hearing aids. So sometimes that can be a conductive thing and it gets better. There is a question about how frequently the tethered cord can reattach. It can reattach, but the thing that neurosurgeons are very cautious about is anytime you do surgery there, it can cause some adhesions. So you don't really want to go in multiple times. You want to, if you need to go in a second time, you want to be very thoughtful about that. Yeah, and I think it is hard to get a good hearing test for some kids, and whether you're getting sedated, whether there's a sedated procedure somewhere else, can we add a sedated hearing test? And I think too, especially when kids are young and they might have fluid and ear infections, that how do we make sure that they are optimally hearing so that they can develop communication and understanding well? All right, next slide. I'm looking at my time. Dental is really hard, right? So dental problems are common, and adult dental care is hard to find, particularly similar to the comment about podiatry. Finding an adult dentist who can adapt and support individuals. We're really struggling right now at Children's because there's so many people who need in, and how do we it's hard to get in. So all right, next slide. So I think, we've probably hit some of this. Oh, puppet response and hearing tests. He passed and I failed. Uh-oh. All right. Well, it's good if we don't hear it either, that we go get our hearing tested. Maybe we don't want to hear everything, but it's all good. But I think too, some of these sound like they've come through a little bit in the chat, but I'm curious, either what things have persisted, how have you managed things, how have you gotten provided? Like, I think too, and I have a few slides on this, but the adult healthcare system is so different than pediatric. And, how do you get them to listen and also think about the importance of treating things so that we can participate, so that we're not in pain all the time, so that we can stay mobile and continent. I don't know if anybody wants to, this could be a belly aching part of the talk. And I'll look back through the chat a little bit.
I just wanted to say my daughter's only 9, but we've had the privilege, like we live in Akron, Ohio, and so it's about 4 hours to you guys in Cincinnati. So we see Dr. Wiley, and we were able to go see Dr. Melman to help my daughter kind of keep her mobility. So we're working on getting her to walk again after having a displaced patella. But I don't know, like, if you have any resources, like people who don't have access the way we have access, because we've gotten, like, we thought she had tethered cord, so we got a neurosurgeon up here to say no, and then we got a second opinion down in Cincinnati. So I think we have a lot of privilege with that. So I don't know if you guys, I don't know if that would be helpful in this group, but I just feel like,
yeah,
it's just really helpful it's been helpful for us.
I mean, one of the things that, and again, we're pretty open to, if your providers in your area want to reach out and talk to one of the specialists. So what I'm pretty certain that Dr. Melman would be happy to talk to folks in other areas about, like, here's my approach, here's what's important in RTS. I mean, he is probably somebody who's seen more folks with RTS than most orthopedic surgeons. I mean, we have other really good orthopedic doctors too, but he kind of was historically the one that Dr. Rubinstein tapped. So he needs to keep teaching others, because, I don't think he's going to work forever, although I don't think he's retiring yet. But I think it's also why we've also tried to build, like Celia did a great job, and Ilka, about some videos on the USAID website that are driven by physicians. The goal, while probably families watch them more than physicians do, the idea was to do a very 3 to 5 minute, hey, these are the things to watch for. Here's the things as an orthopedic surgeon you ought to do, or as a GI person, here's what I'm watching for. And here's my approach. And I think we did one from neurosurgery, ophthalmology. I mean, we had quite a few. So I think that is certainly a resource. And then if providers in the area want to reach out, we do sometimes talk to other docs about, what's going on, or, I mean, I think I've had questions about growth, and, just sleep and a lot of things. So.
Yeah, and the videos that we did, I really have to say, we worked really hard on getting all of our experts who have probably seen more patients with RTS than many others, to really talk in those videos. So they are definitely worthwhile watching, as well as sharing, at least if you can, with your providers. I know they won't necessarily always be like, oh, sure, I'm going to watch this, but it could be really helpful if somebody's interested, or if you have like an orthopedic surgeon who would want to learn a little bit. I think there's a great video with Dr. Melman. He had done a great job with that. So yes, Celia, can you, okay, great, fantastic. Celia just put in the chat the link to the videos.
So if you scroll
Yeah.
all the way down to Rubinstein-Taybi resources, so you'll have to scroll down, you'll see RTS videos, RTS booklet, and our fact sheets. They're all there.
All right. Let's go. Let's kind of keep moving. I do see, boy, lots of surgeries, and that's not very fun. I think too, I often, when I talk about adult health care with families, just also even understanding the different kinds of primary care providers, at least in the US. I'm not as knowledgeable in other countries, but, internal medicine is predominantly trained in adults. Med-Peds is basically, these are folks who are trained both in internal medicine and pediatrics and board certified in both. So they really are some of the people I go to frequently, because they should at least have an understanding of pediatric onset conditions, and as well as the adult piece. I do find family medicine practitioners being also quite often quite good. They also get training in both adults and children. Maybe a little less time in pediatrics. So it's very kind of is like, what's their comfort level? But they are also often, sitting in places where they're treating a lot of mental health conditions. So sometimes regarding if you have a loved one still needing some medications for more behavior and mental health, they may actually be more comfortable than a pediatrician would. And then again, I think regionally, what's in your area, who's comfortable. Sometimes it's like, who do people know that take care of more complex patients? Sometimes it's even like checking with your own doctor. What's their comfort level? They know you, you know them. If you like them, would they then respect a little bit more your inclusion in the care? Because I think too, as much as we want individuals with RTS to be part of the process and convey the information that they're able to, we know that sometimes we need information from a lot of perspectives. So there was, so one of the papers did talk about the most common adult specialists: ophthalmology, cardiology, pulmonary, neurology, ortho, endocrine, psychiatry, and GI. So again, that kind of gives you that sense of, I still might need an adult specialist. And even when I'm working with families and looking at that transition mapping, I'm like, okay, which ones are really going to be hard to let go? Are there some that are going to be easier to make that transition? Who do we have in the area that does adults? Again, this is harder for me when people come from out of town, but they may go, yeah, this is a lower yield issue. So this one I might start with an adult subspecialist and start peeling that away so that you can, get some of those things transition and then work a little bit more gradually. Again, that kind of depends on the area. It depends on the issues that you have. And it also probably depends a little bit on insurance. So, and sometimes the pediatric settings, are they starting to limit the age of folks they see? So there's all those things that go into play. We'll go to the next slide. So,
Can I just add one thing, Susan?
Oh, sure. Yeah, absolutely.
Yeah, so with the many healthcare transition sessions that we have done, we have one physician who is a Med-Peds physician on the adult side. And she always says, when you transition into that adulthood, what you need to do when you have, youth, young adults with disabilities, you go and introduce them, go to a medical provider that might be new to you. She always says it's kind of like dating. Yeah. So you go for the first time, you check them out. You may or may not like them very much, but you're not 100% sure. If you're not 100% sure, give them another try. If your child still does not seem to connect, or you feel like, oh my gosh, they're so not interested in learning anything from me, then you might have to move on. And how, you know, we all know that's terrible if you have to do this. But I think the idea here is when we move into adult healthcare, we usually come from systems that have seen and known our kids for a long time. And now we have to go to people who don't know our young adult children and may not even know about the condition, right? So you start in some ways over again in a very different environment. But I'm just saying all of this, so don't give up if the first time it didn't work out really well, or if you really didn't like the first provider. Give it another try, or give somebody else a try. Don't just say like, oh, this is not going to work with my kid.
Yeah, no, that's a great, it's funny. I always remember and actually she says it is like dating. It's like, yeah, you kind of, I'm like, will I have coffee with you again or not? No, and this is just a study that came out of our institution as well, looking at just family experiences with care coordination. So there was a survey given, and the higher number is a better number. But again, looking at those older folks, you know, they're kind of similar to the younger folks too, in terms of feeling like they're getting coordinated comprehensive care, but where I think, you know, things are a little bit harder, you know, I get, or maybe this is more like what people want. There's less interest in general information and more interest in that specific information, which makes total sense. You already know the general stuff. It's time to dig deeper and kind of, you know, get the nitty gritty. So the next one, though, kind of also really speaks to, next slide, please, where the gaps are, or, you know, so where are people feeling well, actually more like what's important to you, but also, you know, how, I don't know how that's really going, but the things that the adults really were.
Hey, Susan, I don't know if you can hear us, but you're really breaking up, so we cannot hear you.
Can you guys hear me?
Now we can.
Okay, sorry. Just, I think this was kind of interesting just to see what are the family, you know, interests. And you might also walk in going, hey, this is my priorities. And so then that also helps you have that conversation with the adult providers. Okay, next slide. I think we're getting close. Well, maybe not too close. Next slide, please. So I think too, where I think about what's different, back one, please. Adult healthcare tends to, like pediatrics is a lot more forgiving. If you're a little late, we're going to try to work you in. Adult healthcare doesn't always allow that. I think, again, how do we include
Susan, we can't hear you. I'm going to try to text her. I don't know if she can hear us.
All right, if folks could just be patient, we'll get her back. Susan, we keep losing you. Can you hear me? Oh, off she went. We'll be patient. She'll come back in. Yeah, I was thinking about that, but everybody here's got their video, but maybe Susan's, yes. Helen, you might be right.
Trying to get, am I back? I think
You're back.
My internet's not very happy. I don't know why. Okay, next slide. Well, I guess we'll just we'll just keep going. Oh, that's a good question. What are the age ranges we have today? But let's go to the, yeah. So I think too, like where this is also where I think we can learn from each other, particularly those who've kind of made it to the adult areas. What have you done to advocate? What is, you know, what have you found that's been helpful? Yeah, we've got young folks and we've got some older folks. I think I probably, oh no, I still have all the. Anybody want to talk about what strategies you use to successfully get into the adult world and be heard? and cared for. All right, well, we can keep moving.
Here comes Jennifer.
Oh,
Susan.
okay.
I'm just going to give another plug for Cincinnati Children's, the resources that Celia put up. One of the things that they include are these great, just like one-page sheets. And we met with a new doctor for my son recently, who's transitioned to an adulthood, and he could not say enough good things about it. It has all the links, so the doctor can do additional research if they feel they need it, but it's just this great one-pager that can slide into their file and give more information. And Cincinnati Children's developed it. It's great. It's very useful.
That's great to hear how you use that, because I think that was that was our goal, because we know that doctors don't want to read a whole lot. I mean, they do, we read a lot, but like we want it in bullets, or we want it short. You know, if you give me
like everybody, and
yeah.
this just gives you opportunity to take a quick look during your consultation.
Right.
And then if something else needs to be looked at during lab results or additional testing, they have it right there. It's really accessible. And that's what we all want, right? I mean, it's
right.
Doctors are as busy as the rest of us. So it's a great little one pager for them.
Yeah. Well, and I'm definitely seeing how insurance in the US is prompting worries and challenges. And I totally understand that too, because again, you know, if your child is on Medicaid or moving to Medicare, you know, who will take that insurance? Or, you know, will you get the right care? And that's, you know, that is tricky. And I've even had some families, maybe not with RTS, but like Medicaid is how they're getting adult day programming. And so if that changes, you know, what are they going to do? So I guess I'll just say, talk to your congressman. Like, because two things, we've got to get providers receiving it and you know, and not just saying, I won't see you if you have that insurance. Because again, that to me is a horrible disparity. But yeah. All right.
And I think I'm sorry, Susan.
Oh, go ahead. Yeah.
The other piece, and I see Sandy in the chat having posted this. I think sometimes we find more pediatrician and pediatric specialists who are also willing to give it a try, to learn about it. I think it is much, much harder in the adult world, you know, because they struggle with even kind of common childhood conditions sometimes. And so I certainly understand the challenge of really finding adult providers who take the time, who are willing to read through something and take on. But on the other hand, just like Susan says, you know, we always have to put ourselves in that position. What can we do? What can we do? And how can we educate? And so short messages like one-pagers, you know, giving it another try, or if they are really not willing, finding somebody else. I know it's such a challenge, but at the same time, I really want people to not feel discouraged, to go out there and say, like, here is my adult child. My child has a rare condition and I need medical care, and we are here. And I feel like, you know, don't get discouraged. Continue and talk to other families and talk to others and ask them what they have done in order to move along in their journey from adult providers.
And I see like, there's just not doctors who are taking Medicaid for adult patients. And that is a big problem. I mean, even in Cincinnati, it feels like there's two general pediatrician practices, those that take Medicaid and those that don't. So, I mean, that I see that just even in pediatric care to some degree. I don't know. And again, you know, it's not everywhere, but I think two things I think about is university settings or, you know, more urban places, almost because they may be getting more funding or you know, Medicaid rates. Like federally qualified health centers get a higher Medicaid rate, and therefore they can do more and they can spend more time. The other thing I would say is sometimes maybe just knock on the door. Like I've also had some pediatricians who will take a sibling, you know, so other people in the family might have insurance and then this child doesn't, but would they be willing to take one or two here and there? So, yeah,
will say,
that's a
Dr.
great,
Wiley-
I
Yeah,
like
sorry.
the geriatric statement, because I think too, I always think that geriatrics is the developmental pediatric, you know, mimic, because it is about function and quality, and it may take more time, but we're also, yeah, looking into things that are more complex. Sorry, go ahead. You guys can.
No, I just was going to concur, and I've talked to a couple parents. Most recent stories I've heard is exactly what you said, where they kind of knocked on a door and said, "Will you please?" And literally, a mom brought her child somewhere. It was, I don't recommend this, but it was a situation where walked up to, saw them in a social situation, said, "I want you to meet my child. I've been trying to call your office," kind of getting through. And I think that goes back to what Dr. Riddle was saying, which is just don't give up. Keep on trying. Advocating is a huge part of this, and so just keep knocking on the doors and keep having the conversations in your community too. To, you know, what we're talking about here is big A, advocacy and policy change, to have more physicians see that space, helping geriatric doctors see that there's so many parallels, that this would be an easy step in for them and things like that.
Yeah, I think they're overtapped too, so they have more business than they can handle. Well, it's gonna get, like, my next topic is like even more discouraging. So let's pop to the next. We can just go on to the next one. That one more, thanks. I mean, I think too, oh yeah, sorry, back one. I also try to look at, like, how are folks doing? Where are they living? Kind of how are, what sort of independent skills do they have? And again, the data is a little old, but, most folks can feed themselves, many can dress, but even the toileting, and toileting is a really important skill, and that does make it hard. I thought it was interesting too. So this was also out of our, a questionnaire, and actually questionnaires and rating scales out of a population that Cincinnati queried. And while numbers don't make tons of sense necessarily, the thing that I was concerned about is on adaptive skills. So how can I function day to day? We actually see a decline or a difference among the teens and the adults. Now, again, that could be that you're losing some skills, but it could also be that this is an older group of kids who didn't have the same opportunities as teens. So I don't know that we have a great way to fully interpret that, but I think my concern was there seems to be more needed for support as folks get older. Next slide, please. They also looked at, Stevens looked at things like, what are you doing housing wise? And again, this is an old cohort, and this also very much is linked to what is in your community and what you've advocated for and what are those supports. And again, I know adult housing and locations to live are another big worry spot. But again, this kind of gives you a little bit of a sense of how folks were doing in a prior generation of older folks. And then we'll just keep going to make sure we have a little time. Well, how about we just keep through a couple more slides and then we can hit things. I think behaviorally was the other thing I wanted, because that also does really link with functioning. So again, Stevens asked different behavioral characteristics, and this was an adult cohort, but kind of that being easily upset, good eaters, hardy grubbers, issues sometimes with lack of awareness of danger, being, kind of what are your social interactions with and that sort of thing with others. And then again, overly friendly, about 40%. I feel like we do see a fair amount of fear and anxiety sometimes that also pop up. So next slide, please. These were things too, again, it's a little hard to see, but in the older group, what was reported a little more commonly, this was an older paper too, 2012, is being nervous or high strung, difficulty concentrating and paying attention, being fearful or anxious, stubborn, and I would rather use willful, but and then difficulties with coordination and being a little bit clumsy. So those are also kind of fairly commonly described in parents of adult children with RTS. Next one. And then, that one didn't come out very well. This was a paper, again, this was the paper from Children's where they actually did rating scales, and we're seeing a fair amount of, like, basically these folks met criteria for ADHD, about a third with autism, and then some other kind of conditions, more commonly anxiety and some a little lower rates of mood problems. Next slide. And then they did try to look between RTS 1 and 2, and the EP300s had a little higher scores on social phobia, but I think it was a little tricky from a number of, just the numbers in each group. And then a little more common to have like stereotypic behaviors. That's probably a little bit more of like, got to have things a certain way, or a little bit of stimming. So again, you'll kind of see, where, again, these weren't necessarily clinically diagnosed, but these are scales that would say, hey, you may well meet this criteria. So panic attacks, separation anxiety, fears, and so forth. So OCD and anxiety, and those are hard, like, right. So I think what's also hard is finding, that's okay, you can keep going. Those are really hard because it's hard to find people who can adapt and support loved ones in that way. I think, when I think about anxiety, you just can't logic your way out of it. And so like, how do we help folks calm and kind of settle when they're feeling so bad inside? So we can, I think this is probably a reasonable place to kind of offer up some shared knowledge and ideas. Because again, it's really hard to find. It's hard to find adult providers. It's even harder to find mental health providers who can adapt to cognitive differences, and or like, you might have the toolkit that what to do with anxiety, but then how do you map it to what's going to work for an individual with RTS?
I had a question. Are there specific therapists that work with nonverbal kids? Like, so I feel like,
Yeah,
we've had a lot of like trauma and different things that have happened in our, like, people, like, grandfather passed away, things like that. How do we
right.
approach that with nonverbal kids?
Yeah, I mean, I think there are, but they're really hard to come by, right? And again, I feel like I've sit in a candy store. I know people like, I do. We have so many resources at Cincinnati Children's. And I think there's like an element of, is there more play-based therapy that can help? How do we manage grieving? I think grieving is a great, I should have added that one too, because, as kids age, they may lose grandparents or they may lose loved ones. And, how does anybody manage their grief? And then how do you honor who you've lost, but also, I mean, I've had kids who, not necessarily with RTS, but were told their loved one was in heaven, and that's totally fair. But then anytime somebody would go to the restroom, like, are you going to heaven? Because it was clear that meant you're not coming back, right? So again, there's also that reassurance of the best we can for stability. And then, I don't know, Dr. Riddle, if you have other thoughts on that. I mean, I think too, we often think about, well, what's the behaviors that we're trying to support, but also, how do we, if somebody's really sad, how do we support them in that sadness? How do we help them find the things that they feel better about? What are some lists of things we can do that when we're feeling anxious that might make us feel better? I mean, we all do this, right? Or if we're trying to honor somebody we've lost, again, like, we don't want to spend all day doing it, but it's, is there something that we did that, and crying is therapeutic. And then, but then how can we take that and remember they're inside us, I mean, I don't know. I think it's hard.
I think it's very hard to find people. What made
Yeah.
me think, one resource that might be helpful, could be helpful, I think, is we had April Weintraub, who is a sibling of a young woman with RTS. She's a speech language pathologist. She's in New York. She does amazing work. And I mean, obviously her focus is on developing speech. However, I think she has also done a lot of work around, like, how do you work with and understand when somebody is nonverbal in terms of their communication needs. So I'm wondering, Celia, if she would ever be willing to directly connect with people. She's generally very, very open. And I'm not saying that she's the solution per se. So, I mean, I'm not, trying to advertise her to say like, oh, she's going to have all the solutions. I'm just trying to think, because it is so hard.
Well, yeah. And I see Jennifer also talked about like the ARC and also chapters. And I think in like Ohio, there's county boards of developmental disabilities, and sometimes they do have behavioral people, which also like link to them, which is also kind of intended to do mental health support. Again, it's really hard though. They may have some skills, but do they have the unique skill set for whatever the problem is, but they understand the adaptation for disability.
And I will say that April did present for us in the virtual series and very much created an open door. So what I could do is provide that link for folks to just kind of hear what she says about how to really kind of tap into that space. And I think as a sibling, she has a unique perspective too, but yeah.
Yeah,
So-
I see like Natasha has a similar question in
Yeah,
terms
I
of-
was gonna say, I think our chat has given us a gajillion new topics to go over. So, right, like
Oh.
particularly like, kids who are nonverbal but still are communicative, how, what
Yeah.
are the ways to support that? Yeah, I think that, so I guess I see two other things. I mean, I'd be curious because I think somebody asked like, hey, is there value in labeling a child having autism? I think that's usually a conversation that I have too fairly frequently is, is this going to allow a broader understanding or different expertise to join your team that helps move things forward, especially in the communication and behavior realm? So I do, I think that's also, sometimes schools are already doing everything, but is that going to change things a little bit? And I mean, they should be meeting a child's needs without a label, but sometimes that opens up some funding streams for behavioral intervention, or in some, like our state has an educational scholarship, so that would actually allow you to have more choice, but again, that may or may not work for you. So I think those are conversations. And I guess too, if families feel like, hey, this opened a door, or it limit, what I always want people to understand is, even if autism is a label, I don't know anything about your child yet. Like, it seems like that's it. Yes, I understand something's going on, but I don't know specifically what your child's needs are. And that should not turn into a one size fits all approach.
There's one other question in the chat about studies with overeating and not recognizing
Yeah.
the feeling of being full.
Yeah, and I do like, so I'm just gonna, Jennifer also talked about like social stories, and those are helpful with the speech pathologist, so I totally agree with that. I don't know of studies, but I certainly agree that like, I mean, there are some other conditions too. I might have to go look at the literature on this, where it seems like there's just no off valve, right? So I do definitely recognize that for some kids, we actually encourage portion size, locking food up, because, as soon as I'm done with one meal, I'm thinking about the next and what's going to be for that meal. And some of that's like an anxiety and predictability. But that's also like, it feels like kind of painful to cycle through that all the time. I think too, nutritionists can be helpful, particularly if they realize that, I mean, some kids are selective and they're kind of picky, and you're not going to necessarily expand that out. So you're going to have to work within the food frames that you will eat. But how can you expand some of the nutritional choices? I do think, there's one family that said I'm really amazed this worked, but they basically, this was an adult child, gave a small mini fridge, and this is the food for the day. And that individual learned pretty quickly that, oh, it's all gone. I don't have anything the rest of the day. And then like mapped, like kind of portion controlled a little bit better on their own. I mean, I'm super impressed that worked, because I don't know, as a parent, I'm not sure I would have like trusted that it would have, but I probably would have been scared. So I don't know if anybody's had some other strategies with the mini fridge that, okay, great. So maybe the mini fridge is, now we need to do like an intervention trial, right? So how many people want to try a mini fridge with, this is your daily aliquot. 4 years old though. Okay. But that's good though, because you're getting that patterning early. I think too, our, food is so cultural, it is social, it is, and our own, habits as well. I think it's really hard that, to limit one individual's access to food if the whole family's not trying to live a healthy approach. But yeah, it's hard. I don't have any great answers on that one. I think we'll have to. All right, did I miss some of the questions? I think there was a lot of good comments and a lot of good sharing. Let me see. I don't know that I have a whole lot more. Let's pop. I think I just maybe one more slide. It's probably my thank you slide. Yeah, I mean, I think no, yeah, you're one more. I I did have that one. Yeah. I mean, I think too, I know Celia and Dr. Riddle have worked hard on this with our OKI group, is like trying to find those when we do an outing, is there something that's like filling parents back up? Because if you can't take care of your own health, it's hard to take care of others. And that, I know that's like haha. But it's true. And so how do you find that space? So I think that, I mean, that's pretty much the end of my slides. I think my last one was just thanking all the families who've taught me so much, because that's really has made me a better person, a better mother, a better clinician. And also I've learned so much from other professionals too. So I feel very fortunate to have been able to walk alongside so many people.
Jennifer, I'm going to make you my sidekick. So Jennifer Hunt also put in the chat about Ohio P2P.
Oh,
And
yeah.
as that self-care piece. So Jennifer, you're invited back every time to sit there poking and prod us.
Yeah, I just poke away.
So
because we
isn't
did
there
do
within the US, or there peer-to-peer in every state?
It's
Or-
not organized the same way. There are definitely
Okay.
family-to-family health information centers in each state.
Okay.
The Ohio peer-to-peer model is modeled after the P2P USA. You can, like, literally, if you type into Google P, the number 2, P, USA, it will get you on their website to see who is all a member and in which state. But it is a great way to connect with other parents. So it's a model where peer mentors get trained. So if you feel you have a lot to give, and I can see in the chat, many of you have such great ideas, right?
Mhm.
And you get trained just in terms of boundaries, in terms of like, how do you do this best? And then if parents reach out to us who want to be matched with another parent because of, I want to talk to somebody who has a kid with RTS my age, or I want to be matched with somebody who really has dental issues with their kid, or somebody who went through puberty to tell me what to do with my 12-year-old. You get matched. And then you can you like have that match relationship, but we have also seen that people become friends. So once you're done with kind of like the matching, we really kind of step back, and then the families talk to each other. And I think it can be extremely helpful to just even hear somebody else is just like, oh, we're totally in the same boat, or we can connect. And we do this for families with all kinds of different conditions, but we had families who had become friends. They're 4 hours apart from each other, but they meet in the middle every so often. So that's definitely something just in terms of filling your own bucket. And really finding others who are like-minded, where your child can have fun, and where you can have fun, and where people understand your kid and love your kid. And you also get to meet with other parents. I mean, the Facebook groups, I think, are incredibly helpful to families too. So if you're not on the Facebook group, you might want to check out one of the groups. And I don't know, Celia, you know more about the Facebook groups than I do, but that is another great way. I really think we all need to fill our buckets. And it is important that we all stay healthy, physically as well as with our mental health. And we can't do that if we are only giving, right? So it is really important to also connect with others.
And I think too, like we've kind of had this conversation sometimes, if you are really, I mean, RTS is pretty rare, and we have folks from many other countries as well. And so yeah, I think the internet is super helpful, but even linking with other families of kids with complex conditions, there's a lot of unity there and a lot of similar experiences. So it's nice to know people who understand your journey, both like maybe because their child has RTS, but also other other families may have some really good connections. So I guess I just always want to plug that. I'm hoping, yeah, Celia, housing. I mean, I think that's another one. I'm like, this is transition is a whole week, right? So housing I didn't get into, and I don't know if there's a quickie answer to that, or we, think about
There's
that.
not a quick answer. I can tell you that housing is very challenging and complicated. However, there are people who have done it very well. There are different models. So I'm wondering, so we also do a whole transition session, like a whole transition series that focuses specifically on transition age youth. It is not specific to RTS, but it is specific to youth and young adults with developmental disabilities. Maybe Celia, we can also share the sessions with this group and the flyers for the sessions, because they address things like healthcare transition, housing, guardianship and alternatives, financial planning, all of those things. And we would be happy to plug you into those groups too. It's the same kind of model. It's a virtual kind of like session that you can attend, and then you get the slides afterwards. So that gives you a broader perspective. And the housing wouldn't be specific to RTS, but it is going to be specific to people living in Ohio. So I think that might be helpful to you.
And I think what I'll do is pull together a couple of resources. I was just now trying to find my face. Oh, good. Natasha.
Yeah,
put them in.
somebody
Thank
put
you,
the
Josh. I was
Facebook
like
group
searching for
in.
the Facebook page.
Yeah.
You guys are on fire today. I'm
Yes.
like trying to keep up with all the possibilities, but I did want to address, Karen, if you want to, there are a number of families in South and Central Ohio, and our OKI, RTS OKI
Yeah.
group is going to be gathering soon. And so that would be a great space and place for you to connect with some of those families, but certainly
And you
there's
guys do some unemployment too. So those.
Yes, so I just saw
Yeah, they're-
Jennifer's.
yeah.
So Jennifer, I'm going to have Celia like send out something about our other many different educational sessions that we do. So we do
Mhm.
things like housing and employment and finances and all of those things.
Yeah. So I'm surprised, and maybe it's depending on how it goes, but they should be getting those, I think, as they go out from the USAID too, as part of the regular mailing list, I would think, but I'll have to talk to Jennifer and
Yeah.
Rebecca.
I don't
and
know
follow
if
up on
those
that and
lists
make
have
sure.
all been combined, Celia. We might have to look at that,
Okay.
like with
I'll
the
have to look at it
newer
closer.
people. And Andrea
Okay.
is asking about the reunion. No, we do not have a reunion
Oh.
planned yet, but we do have a nice event planned very soon, and information will come out. Stay, yeah.
This post.
Save the date. I
She-
just put April 26th, save the date.
Yep. Save the
Yes.
date. Come hang out with us. It should be
Yes,
super
April
fun.
26th, we will be at the Newport Aquarium, and we'll have a really fun day. So
So we're having a reunion?
We're
lots
having,
of parents who want a reunion.
Oh,
And
cool.
they want to gather.
We
Yeah,
are
I think
working on
Okay.
many different ideas.
Love it.
It's not always so easy, right?
And I want to, we've got a self-advocate on here. I'm going to say her
Yeah.
name wrong, but
Oops.
Atha I just want to really thank you specifically for your advocacy in the chat.
Yes.
I just so appreciate everything you're sharing about your own personal experience. So thank you.
No, thank you, thank you. And I just, I was going through my own experiences growing up, not knowing that I have RTS. So when I did find out, of course, it was too late and all that. But but yes, it definitely bang on. Thank you.
Yep, thank you. All right, so our next one coming up is Tuesday, May 6th. So you'll see information because Lauren is awesome about getting that out, and we hope you will join us. Evaluation in the chat. Hold on one second. I want to make sure that gets put there. It's on a QR code, but I want to find the link and it's in the chat. So I'm going to have to go back. Here we are.
Mhm.
Hold on one second. Where'd it go?
I think I have it copied. I can share it, Celia. Thank you for
Okay,
sending it to
great.
me.
Thank you.
Mhm.
Yeah, between the two of us, I think I got it too. So we'll get it in there. There we go.
And thank you all for your knowledge and information. That's always makes things better. So
Please don't forget to do your evaluation. It's important. So we appreciate you, and put all your great ideas. We have the chat and I will save that, but any great ideas for upcoming speakers, please let us know.
And we'll give you 2 minutes back of your evening.